Good morning, good afternoon, good evening to all our healthcare workers attending today's webinar, Medical Management of Sickle Cell Disease, Pain Management, and Opioids. My name is Sanjeev Wadhwani, and I'm a board member for SCAGO, and also volunteer of this organization and work as well as on the research committee. Before we begin, I'd like to also introduce Dr. Ziad Soul, who's a hematologist and transfusion specialist, who'll co-moderate the session with me. And I'll let Dr. Soul also introduce himself briefly as well. Dr. Soul?
Yeah, thank you, Sanjeev. So it's a pleasure to be here with everybody. We're so happy to have healthcare providers attend this session and educate themselves on pain and sickle cell disease. So my name is Dr. Soul. I'm a hematologist at the London Health Sciences Centre in Ontario, and a transfusion medicine physician, been working with SCAGO and Londre for a few years, and it's our pleasure to welcome everyone today.
Super. Thank you, Dr. Soul. Before we get started as well, just a brief announcement, and I think I would be remiss if we didn't acknowledge, let's say, a moment of celebration that happened last week, a major milestone, and this was really the progress of Bill 255. And on June 3rd, Bill 255, which was a private member's bill, was co-sponsored by two MPPs, Andrea Kanjan and Rudy Cozzetto, to raise awareness of sickle cell disease and thalassemia, received royal assent. Unanimously supported at the third reading. It really proclaims that June 19th as Sickle Cell Disease Awareness Day and May 8th as Thalassemia Awareness Day. So it's really a landmark moment for almost the nearly 4,000 people living in Ontario with sickle cell disease, and a great opportunity to further raise awareness in this devastating disease as well as within our community. So congrats to everybody involved. It's a monumental effort. It truly takes a village to, look at the key intersection between policy and advocacy and all the folks involved, and also to really be ahead of, let's say, our first inaugural World Sickle Cell Day, which will be next week. And I'll share a little bit more about some of the events going on next week as well. So with that, I'd like to just go through a couple logistics for today. The first one is that the session is being recorded. We know a lot of you are taking time out of your busy schedules to try to attend, and there may be some more that would really like to hear these sessions. We will record it and make it available. We will mute all the attendees just to avoid any background noise while the presentations are going on. And if you have any questions, there's a Q&A feature at the bottom of your Zoom window. Feel free to add the questions in that Q&A box. And after our last speaker, we will go through the questions and triage as many of them as we can. The last piece I just want to mention is after the webinar closes, you'll be directed to a quick survey. And this is really important to us at SCAGO because we really try to tailor the sessions to our community and what's important for you, and also to get your feedback as to how we continuously improve. So really a big thanks in advance for your candid feedback. With that, I'll transfer over back to Dr. Soul to give us an introduction to our speakers, as well as some of the key objectives we hope to accomplish in this session.
Yeah, thank you so much, Sanjeev. So it gives me great pleasure to welcome our two speakers for today. Dr. Melanie Kirby-Allen, who's an esteemed pediatric hematologist oncologist in Toronto Sick Kids and the University of Toronto. We've received lots of mentorship from her over the years, and she's definitely someone who has tons and tons of expertise in this area, and we look forward to her speaking to us. And then after Dr. Kirby-Allen, we'll have also an extremely esteemed adult hematologist, Dr. Pendergrast, who has extensive expertise in sickle cell disease, pain management, and transfusion medicine. And he will address objectives regarding patient and healthcare provider experience with pain management and sickle cell disease, as well as a variety of pain syndromes in sickle cell disease. So without further ado, we'll have Dr. Kirby-Allen speak for approximately 15-20 minutes, and then Dr. Pendergrast will follow the same, and the final 15-20 minutes will be reserved for questions and answers. And we will try to stick to the time, so hopefully we'll try our best. All right, Dr. Kirby-Allen, go for it.
I'll share my screen.
Absolutely.
Thank you very much for asking me to do this, and welcome everyone, and thank you all for joining us. I'll be not very long, just to talk about pain management principles in sickle cell disease, and then Dr. Pendergrast will talk about more details of pain management. Nothing to declare. The objectives of my presentation, I would like you to understand the pathophysiology of pain in patients with sickle cell disease, gain a knowledge of assessment of pain scores. This will be very brief, and appreciate what we call the 3 Ps of pain management: pharmacological treatments, physical and psychological aspects of care. So pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And this goes for pain for any etiology. And pain, very importantly, is what the patient is experiencing, what they say they're experiencing. We should not try to assess the degree of pain based on the appearance of the patient. Too often, our patients who may have a higher pain threshold based on the fact not that their physical makeup is any different, but that they have had pain repeatedly. So they may not show, not necessarily a high threshold, but the outward appearance may be different. They may not be grimacing and screaming and crying in pain like somebody who's for the first time cancer patient or first time trauma patient might experience pain. And so looking at a patient and saying, oh, that patient doesn't seem to be in a lot of pain, that's erroneous and not fair to the patient. So that's very important to recognize. Pain is what the patient says they're experiencing. Pain is a primary reason that many of our patients with sickle cell disease will seek treatment, and most often it's for acute recurrent painful episodes. Our patients can also have chronic pain syndromes and neuropathic pain, which we won't talk a lot about today. And they would tend not to present in the emergency department that much with chronic or neuropathic pain, but more acute recurrent painful episodes. And our whole aim of our comprehensive care clinic management is to prevent pain in the first place by disease-modifying agents, and to teach our patients how to manage their pain, to prevent them getting to the emerge. So by the time you see them in the emerge, it's because they've tried at home and it hasn't been adequate. The acute painful crisis is a hallmark of the disease of sickle cell disease. It's the #1 cause of hospitalization or seeking care in emergency. It's recurrent, it's unpredictable. It can be localized to a particular bone in the body, or it can be multifocal at presentation. And many times patients would have a target organ, a target bone that the pain would recurrently be present in. Patients with sickle cell, most severe form of sickle cell disease, sickle cell anemia, hemoglobin SS, homozygous S, and also patients with higher hemoglobins tend to have more frequency of pain. The precipitants for pain can be, it's varied. It can be recurrent, it can be an infection, an intercurrent, little cold, nothing much. A little cold can precipitate them. Stress, we see patients presenting at the time of a new job or exam for the kids or university students at the time of exams, and it must be recognized they're not trying to get out of the exam. It's the stress of what's coming up that can precipitate pain. Trauma can do this, both physical trauma. You may have a fracture for example, a fracture or just a bad bump, and then pain starts in that area and can get worse and spread. And also emotional trauma can result in pain. Extremes of heat and cold. So we see this there's some patients who would come to hospital more often during the winter and have great summers, and there are others that have not so terrible winters, but in the middle of summer when they're much more active, they get a little bit dehydrated from being out in the hot sun running around or being active. It may precipitate an episode. one thing that's very important to recognize that all pain in sickle cell disease is not VOC, is not always VOC pain. So consider the whole patient, the clinical presentation, what the patient says to you. If they say, this is my typical pain, you can take that. But sometimes patients with sickle cell disease can present with anything another patient, appendicitis, cholecystitis related to their hemolytic anemia, a ruptured viscus, a fracture. We've had kids come to emerge with shoulder pain, and it turned out to be a fracture. On the third visit back, the pain at that site not getting better, and then an x-ray is done, and then the history was there of a fall with trauma to that site. So have a wide differential of pain when you see a patient, and then you can cone down to VOC pain. But don't always assume that the pain is a typical bone pain, and unless the patient tells you this is very typical. Pain, just to review sickle cell disease pain. So as you remember, very briefly, sickle cell is a blood disorder, it's a genetic disorder, autosomal recessive. For both parents have to be affected by as carriers. It's a single gene amino acid substitution, and that results in the hemoglobin, which is hemoglobin S, being less soluble in the in the deoxygenated state. So the hemoglobin polymerizes, and that results in a change in shape. So when you deoxygenate, you change your shape. When those red cells go back to the lungs, get oxygenated, then you reform your usual red cell shape, and that can happen a few cycles, and then the cell becomes irreversibly sickled. What happens with VOC episodes is not solely the sort of log jam of a traffic jam of these red cells. That has been our traditional teaching, but we now recognize that not only these sickled red cells cause obstruction, but there's a role in white cells producing cytokines, and in a role of inflammation at the site of the episode. And that helps. One of the things that we give patients is anti-inflammatories, and that can help with the pain management. Sometimes the anti-inflammatory works better than things like Tylenol. So it's a combination of an obstruction, but also the involvement of white cells and platelets. And this information is what leads us now with several drugs being researched to reduce overall VOC episodes. With hemolysis, you release free plasma hemoglobin, and that gets bound up with by haptoglobin and reduction in nitric oxide. So it's a general low level of nitric oxide within the bloodstream, and that also results in increased inflammation and sickling. So vaso-occlusion leads to hypoxemia at the site, at the organ involved, which leads to ischemia and tissue damage, and also chronic vascular inflammation. The inflammatory mediators released from the injured cells of that organ activate the pain receptors, and then the patient perceives the pain. There are 4 phases identified for acute pain cycle, and for an individual patient, they may not recognize these as phases of pain. Sometimes the pain just starts in full-blown, very painful, without a prodrome. Some of our patients can tell us that they feel, what I've heard from them is they feel particularly tired leading up to an episode, or they may have numbness. One person on the weekend had some numbness under the chin, and then that proceeded to a VOC episode involving the jaw. And so that is explained by the nerve being affected by the jaw sickling, but the numbness came before the pain came on this particular patient. So the prodrome could be one of those symptoms. And then also part of an episode, if you think of a person who's having recurrent pain episodes and they're anticipating, I'm going to start taking my medication at home, and a fear comes over, I don't want to have to go to hospital this time. And so they start taking their medication, but fear and anxiety also brings on pain. And when in the established phase, you may have a temperature, you may have an increased white cell count, increased CRP showing that there's inflammation, but sometimes, most of the time, there's nothing on the blood work that will tell you that this patient is sickling. Over time, you may have a drop in the hemoglobin, but do not look at peripheral blood count chemistries and say there's no evidence of sickling here, there's no increased LDH, this patient is at baseline, so they can't be sickling. You may not have any of those things. So you really truly have to believe the patient. Patients don't like coming to hospital until it's unless they really have to come. Pain, in addition to acute pain, which we'll talk about mostly, we can have chronic pain associated by definition over 3 months in duration. Our patients with sickle cell disease are prone to leg ulcers. We don't see that much in North America. In a tropical country, you tend to see more. A vascular necrosis of the hip, you can have a patient presenting repeatedly with or being aware of hip pain, and over time, what happens? The femoral head gets infarcted, and with the pressure of walking, you flatten the head of the hip femur, and that leads to chronic pain and secondary osteoarthritis, which can be extremely painful and require treatment. Chronic osteomyelitis might be present at a bone site, and these usually are recognized when a patient comes back, and it seems like there's a target site there, and the pain is not relieved in the usual way, and even after a week or so of adequate pain control, the pain persists. So think of osteomyelitis and compression fractures also. Our patients have, like any chronic hemolytic anemia, they can have vertebral compression fractures, and those can be very painful. Neuropathic pain is, we also see, this is numbness and tingling, needles and pins in the extremities. They describe as shooting pain, or allodynia, where if a patient has recurrent pain at a site, after a while, the pain, it's like the pain receptors get confused, and even with very mild touching of the skin, you can have a patient saying that they're having pain. They're not pretending, they're having pain from recurrent these pain episodes, and it's like the pain fibers are firing on overdrive. And neuropathic pain control often doesn't respond to morphine and hydromorphone, and needs things like gabapentin or some of the other pain medications. We treat pain to alleviate suffering, to reduce anxiety, which is a vicious cycle getting back. The more anxious you get, the more you get pain. We increase compliance and cooperation by alleviating pain. Reduction in long-term negative effects. People get depressed with recurrent chronic pain. And the more depressed you get this pain cycle of long stays in hospital. So you need to try and treat pain upfront adequately with a lot of support and compassion, and not have patients becoming depressed over time, or manage the depression also. Pain management is a priority. So when patients come to the emergency, we do blood pressure, heart rate, temperature, and breathing, and we want to make a pain assessment in every patient, not just patients with sickle cell disease, the fifth vital sign. And a pain assessment gives us a diagnosis, so it helps us to guide our management of our patients. The big picture describes pain and the effect it has on life, mood. So this tends to be more with chronic pain, problems with sleep, or even recurrent episodes. If a patient isn't sleeping well, for example, because they have obstructive sleep apnea, they have chronic hypoxemia that leads to episodes of VOC involving bones or organs. And we use pain intensity scores to assess the severity of pain and the response to treatment. So very briefly, for children, little children between 3 and 7, we use a FACES scale. This is all available quite widely, so I wouldn't stay very long on a 0 to 10, with the more grimacing, looking at the facial expression as an indication of how much pain there is. For kids over the age of...
Dr. Kirby, just let me know you're at the 15-minute mark, so you have a few more minutes.
All right, thank you. For kids over the age of 4, we ask in terms of a little pain, a lot of pain, medium amount of pain. And this is the numeric pain scale that we use in most of our adults and older children. 0 being no pain, 10 being the worst pain imaginable. Very important in managing pain is just not treating with medication, but also treating medication plus the physical and psychological aspects. So the physical aspects would be heat, massage, exercise, getting them up when they can, and not sitting in bed for very long. And the psychological aspects of distraction. I'm just going to take a quick second to talk about distraction. Many of our adult patients and our teenagers, when they have pain episodes, we give them in the hospital here, we give the little kids, we give them Xboxes and things to distract them. The older kids and the adults will use phones. So even yesterday, one of our kids on the weekend, one of our kids was on her phone, a teenager was on her phone for the whole day. And one of the comments from one of the caretakers was, she's been on her phone. Look, she's on her phone. She doesn't look in that much pain. That's part of distraction. And when the phone is off, then the full pain perception is there. So just to remind you about why we use different methods of pain, we're hitting pain at different sites. We're giving pain. We're giving opioids, which act centrally, acetaminophen, and the psychology, distraction, relaxation techniques. And by doing all of these things, what you're doing is, if you have a patient with a 10 out of 10 pain perception, and you start massaging, the message is going to the brain from the massage, from the heat. That all is competing with the perception in the brain of pain. So you're able to reduce the pain perception by doing not just medication, but the relaxation techniques, the heat massage, and using opioids, non-steroidals, and acetaminophen, all together to decrease pain management. Pain management should be scheduled in the beginning of a pain episode. Don't use PRN pain meds, because then the patient will be calling, and they've set up a vicious cycle of the patient calling for pain medication, and the caregivers who are also busy saying, just wanted medication, yes, to reduce the pain. So do it scheduled for the first 3 or 4 days in hospital. So it's known that you have to give opiates, for example, every 4 hours, because they wear off, the effect wears off. Patients, by the time they get to hospital, have been managing at home, and it's not successful. So they're in a lot of pain when they come to hospital. Recognize that and be very compassionate and aggressive with treatment. So in summary, management of pain includes supportive care, hydration, such as hydration, avoidance of stresses, adequate sleep. If you can get sleep in hospital if you're managed well with your pain. We do preventive measures like hemoglobin F inducing agents and other newer agents, and we use the 3 P's of pain management for care. Thank you, and I'll take any questions afterwards.
Wonderful, thank you, Dr. Kirby. So Dr. Pendergrast, the floor is yours. Go ahead.
Okay, thank you. Show my screen. Is my screen visible?
Yes, your screen is visible, and I just want to take the opportunity to ask, is the Q&A, okay, here we are. It is working. Okay, never mind. So go ahead, Dr. Pendergrast.
Okay, thanks so much, Ziad, and to Dr. Kirby for her presentation, which laid out the principles of pain management with a bit of a focus on pediatrics. And my own specialty, my own practice is in adult patients, and so I'll be talking more sort of towards that population. Don't have any disclosures to declare. And in terms of my objectives, I wanted to focus on an important gap between the patient and the healthcare perception of what pain and sickle cell disease is. We can go over the principles of managing acute pain and sickle cell disease, and then talk a little bit about, in just very brief overview, the different types of complex and chronic pain syndromes, that can occur in sickle cell patients and how not to miss them, because it is important to know the difference between an uncomplicated vaso-occlusive pain crisis and then one of the more challenging complex or chronic pain syndromes that may also present similarly. So sickle cell disease is the most common genetic disease in the world. There's something like 25 million people on the planet who have sickle cell disease. 1 in 20 humans carry the gene for sickle cell. There's probably 300,000 to 400,000 babies born every year with sickle cell disease. In Ontario, approaching 4,000 patients with sickle cell. So it's something that you are certainly going to encounter if you are working in an acute care hospital, particularly in urban areas in Ontario, but sickle cell patients exist throughout the province, and you do need to be prepared to manage them when they present. And they will not present with obvious trauma or bleeding or broken bones, but they will present in pain. And you need to be able to respond quickly and appropriately and according to guidelines on how to manage this. And there are lots of very straightforward and helpful guidelines to follow. In terms of the epidemiology of sickle pain, I think I was going to talk about 2 studies I think really distinguish these the 2 perceptions. This study, which was the cooperative study of sickle cell disease, it was done in the 80s, was looking at pain as defined by symptoms that led to a clinic visit, and the physician, and that could either be in the emergency room or the doctor's office, but it's bad enough to seek out medical care, and the physician said it's sickle cell disease. And so when they looked at the pain experience by that definition, you could see on average patients with hemoglobin SS or S-beta thalassemia with sort of the more severe version of that, compound heterozygosity, had about 1 crisis per year. And if you had a milder form of sickle cell disease like S-beta plus or hemoglobin SC, it was about half that. So that was sort of the overall impression. Now, if you broke down the hemoglobin SS patients, there was a huge range there. So 39% of patients in the study didn't have any episodes at all, as defined by seeking out medical care, whereas 1% of patients were seeking out care 6 times a year or more. And I think you tend to be very skewed about what you think about sickle cell patients if you think about that 1% who are the frequent flyers who are in the hospital very often. And it's easy to think that all patients have that kind of experience of pain, when in fact it's a very, very small minority. But again, that's the physician's perspective at what pain is like. Another study that was done called the Pisces Study, rather than defining pain by, did you go to a hospital and say I'm in pain, but simply asked patients, keep a diary and just tell us if you're in pain, found a very different signal. Here, they found that patients reported pain at least half of their waking days, and 1/3 of patients had pain almost every single day. Only 5% of patients in this study were completely pain-free for the whole 6 months of study. So pain was just something that these patients live with all the time. Very importantly, only 1/4 of the days that they were in crisis, they actually sought medical care. Most of the time, these patients are toughing it out at home and trying to get through it by themselves. So there is a whole sort of ocean of physical discomfort out there that we don't see. And it's only a minority of these episodes where the patients come and seek help. And when you start trying to break down, why did this patient and not that patient come to my emergency room and seek help? It's actually a very complicated thing. It has a lot to do with the intensity and severity of the pain, but there are all sorts of modifiers there having to do with perceptions of fear. If you're afraid of death, if you think you're feeling very helpless, and then conversely, if you're afraid of looking weak, you might sort of avoid seeking out help. How socially isolated you are, what sort of coping mechanisms you have at home. There's a lot of very complicated things that interact with the actual physical sensation of pain that will drive whether the patient comes to you for help. And I thought this quote at the bottom left here was very, very telling. That for a patient to come to you to beg for your help, that patient is at their wits' end. They're on their last thread. And you have to receive them with some compassion, that they're coming to you broken down and are bracing themselves in many cases for, a little bit of side eye or some judgment. They don't deserve that. Treat them with compassion, understanding that the management of their pain is going to be complex and nuanced, and it's not going to be a one-size-fits-all sort of thing. In terms of how to treat pain, there is no shortage of guidelines on how to treat acute pain crises in sickle cell disease. We have decades of these guidelines. They're all free. You can download them off the internet, and they're very easy to read and very straightforward. They're all fairly similar in the overall principle of how to manage acute pain. And they say that you need to start pain treatment quickly, like within 15 to 30 minutes of the patient arriving in the emerge. You should start them on some sort of opioid therapy, start with an adequate dose, and then give it frequently, like every 15 to 30 minutes until the pain is brought under control. Okay. This is not a situation where you say, I'm going to put you on a Q4-hour schedule of pain medication, and I'll give you a breakthrough once an hour. That's how you might deal with chronic cancer pain. This is not how you deal with acute sickle cell pain. But most importantly, this is not unique to sickle cell. This is actually the principle you are supposed to follow for managing any acute pain syndrome. This is the same principle for patients who's presenting with a heart attack, or somebody who's having postoperative complications, or somebody who's had a broken arm. You don't put these patients on Q4-hour pain medication orders. You give them small, frequent doses until you get adequate pain control. You just get on it quickly and pay close attention and bring it under control fast. And that's the humane way to do things, but it's also better for the medical system, because it's been shown, and I'm sorry, I'm going to jump ahead for a second here, that the slower and more reluctant the physician is in treating pain in a sickle cell patient, the longer that patient is going to be in the emerge. So they're taking up your bed, they're taking up your time, and certainly it's making their life more unpleasant as well. So getting that pain medication started quickly will just shorten their emergency room visit, and will quite often decrease the need for them to even be admitted. The reason we tend to resist providing sort of aggressive and adequate pain control for these patients is because there's this fear that these patients are drug seekers and they're addicted, and they're coming in because they're going into withdrawal, or they're trying to get high. That perception is remarkably common. So there was a survey done in which 53% of emergency department physicians and 23% of hematologists thought that at least 1 in 5 sickle cell patients are addicted to narcotics, and are therefore disinclined to give them high-dose IV medication, even when they say that they're in excruciating pain. So that's a very high rate of addiction that's ascribed to sickle cell patients. But if you actually study sickle cell disease and look, do they meet the criteria for addiction? It's very low. It's in fact lower in sickle cell disease than in patients with, say, chronic low back pain or other types of pain syndromes. It's really not the problem people think it is with sickle cell disease, but there's definitely a bad rap that these sickle cell patients get, that so many of them are addicted to drugs. It's simply not true. It's just not borne out by the data. I think what you're actually seeing very often is that many sickle cell patients are not getting adequate care in between their emergency room visits. And so they have no disease modifying care being provided to them. And so the only medical care they get is narcotics. That's the only care that's ever offered to them. So I think that when you have patients who are coming in frequently to the emerge with pain crises, what that is telling you is that this patient is not being adequately cared for. And you're not going to be able to fix that yourself in the emergency department, but certainly it's something that should be acknowledged and recognized. So to this end, we know that many patients with sickle cell disease are readmitted. So they come into the hospital and they are sent home, and then they come back 14 days later and are rehospitalized. it's up to 50% in some studies of patients end up being re-hospitalized after discharge. That suggests that they're not being well managed during their initial episode, and they're not having adequate follow-up care arranged. And that's actually an indicator of poor quality of care, to the point that in the US, this is now tied, the readmission rates are now tied to Medicare and Medicaid funding, that if you have patients who are cycling in and out of the hospital over and over again, you will lose some of your funding because that's an indicator of poor quality of care. So again, another reason beyond simply providing patient-centered and humane care to treat these patients properly. It's something that is now being looked at in Ontario as well in terms of the quality-based procedures that the ministry is looking to tie hospital funding to. So managing acute pain, I think Dr. Kirby went over the basic principles here of recognizing that not all sickle patients in pain are because of their sickle cell disease. Sometimes they're coming in from a ruptured appendix, or sometimes they're coming in because they've whatever, had some a bowel obstruction. But often the patients will tell you, I'm having a sickle crisis. And at that point, I think what's most important for the healthcare provider's perspective is to distinguish whether it is a simple pain crisis or a complex pain crisis. And complex basically means that there is evidence of organ dysfunction going on. And that makes it a true medical emergency. Patients who present with pain, who have signs of organ dysfunction, may die if you don't get on top of that quickly. On the other hand, it's also important to distinguish an acute pain crisis from somebody who has a chronic pain syndrome, who for whatever reason has simply lost the ability to cope. And they've come in with their chronic pain. Maybe it's particularly bad that day. Maybe something else is going on in their lives that has made it more difficult for them to cope. And the goal there is to try to provide comfort and support to that patient, but to understand that you are not going to be able to fix a chronic pain syndrome with one hospital visit or one hospital admission. The goal here is to restore function and then make sure that there is long-term care provided. So in terms of what the complex pain syndromes are, again, just to summarize quickly here, one of the main distinguishing features of a complex pain syndrome from a simple pain syndrome is that the complex pain syndromes often require transfusion support to treat. Acute chest syndromes maybe have up to 25% mortality rate, and it's considered standard of care to offer some degree of transfusion support for those. An aplastic crisis may need some transfusion support as well, not much. A sequestration crisis, you may not need much blood, but again, if you don't give some, this used to be actually the main cause of death in children. Stroke is important to give transfusion support. Intrahepatic cholestasis, very important to give transfusion support. Hyperhemolysis, on the other hand, you must not transfuse. And ironically, this is going to be one of the hardest syndromes to resist the desire to transfuse, because these patients will present initially with what looks like a pain crisis, and then their hemoglobin will drop very rapidly to levels that may be quite frightening, like less than 50. But if this is happening 5 to 10 days after a previous transfusion, this is very likely hyperhemolysis, and you must not transfuse these patients. This will just make the hemolysis worse, and patients can die from this. This is a very complex syndrome that requires specialized hematologic input. But in general, I would recommend that if you have any of these things going on with the sickle cell patients, get a hematology consult, because these are medical emergencies and they do require specialized care. Chronic pain syndromes, often you cannot see them unless you order specific imaging. But the pain, whether it's chronic or acute, is usually easy to tell, because the patient will tell you how long they've had this pain for. If they say, yeah, it just started a few days ago and it's gotten really bad, that's not typical for avascular necrosis unless they've just acutely collapsed their femoral head, for example. But usually this is sort of like every day, week after week, month after month, in some cases, years long of awful pain in their hips. Sometimes it can be complicated by back pain due to leg length discrepancy. You can see it on x-rays or very early by MRI. Osteomyelitis is due to infection, vertebral collapse. chronic arthropathy, malleolar ulcers. These things are easy to see. Either you can see them visibly, like a malleolar ulcer or a leg length discrepancy, or you can see them by imaging. Neuropathic pain, by definition, there is no imaging that will reveal that to you, and you're going to have to go by history, the type of symptoms the patients are presenting with. Rather than sort of being sort of a sharp, specific pain, it's more sort of like the whole body hurts all the time, and it's this burning, aching, kind of unrelenting pain that opioids don't seem to help much with. I mean, they might sort of blunt it a little bit, but they never really seem to take the pain away. And in fact, a lot of neuropathic pain may in fact represent opioid-induced hyperalgesia. So these are patients who have been on narcotics so frequently and for so long that they've actually begun to rewire their nervous system so that they are constant nervous pain fibers are constantly firing, and the opioids are only perpetuating this. This is an extremely difficult condition to treat. Most of these things will require a surgeon at some point to get involved to treat, but neuropathic pain, you need a true pain specialist. And that's going to be not something that you can arrange during an acute hospital visit. The main goal here is to get the patient's pain managed, help them cope so that they could just, get through their daily obligations, and then get them hooked up with a pain specialist, either directly or more probably preferably via a comprehensive care program for patients with sickle cell disease.
Dr. Pendergrast, this is the 17-minute mark. You just have a couple minutes left.
And I am done. So at that point, I will be ready to take any questions.
Okay, excellent. That was wonderful from both speakers. Thank you so much. Right on time. So we have 13 minutes for questions, and I see we have had a few questions, one answered and one placed. We are going to take other questions. Sanjeev, can you confirm, can the attendees speak, or can we hear them, or is it all typed questions?
Right now it's all typed, but but we are happy to take them live. If you just text, then I can, or raise your hand, I can see who would like to ask a question, and we can also unmute any of our attendees if that also works.
Okay, so let me just read the first question from an anonymous attendee. So somebody asked, I would like some information on localized ankle swelling with shooting pain affecting standing and mobility, but not present anywhere else. It was not red or hot to touch. Cellulitis was ruled out and deep venous thrombosis was excluded. Elevation and painkillers and ice pads or hot pad did not help. No diagnosis given till date. And Dr. Kirby-Allen responded, and you're welcome to add, Dr. Pendergrast. Dr. Kirby-Allen said, for patients who may not have an ulcer visible, there may have been neuropathic type at that site before the swelling or actual ulcer is present. Cold is absolutely contraindicated, as this will result in vasoconstriction and reduced blood supply, hence more hypoxia at the site and more sickling. So, if anything, you guys know that heat will cause vasodilation and improved blood flow and oxygenation. So definitely avoid any cold exposure and go for heat when there's a question of pain.
Mm-hmm. I totally agree. I might add that I might get an MRI in that setting just to make sure there's no evidence of avascular necrosis or osteomyelitis as well. Sometimes that can develop even after an overlying ulcer has healed, or it can just occur via blood circulation. I have had other patients that I've actually wondered about reflex sympathetic dystrophy as well, where that you can present with sort of this, throbbing, lacinating pain with edema as well. That's a rare diagnosis. But it is a type of neuropathic pain as well. But I wouldn't make that diagnosis without getting an MRI first.
Yeah, excellent points. And we also have a question from actually one of my old colleagues, Hannah Zeitlin. Hello, Hannah. So could the slides be provided? And I'll let the speakers comment on this.
I would. I'm happy to provide my slides. Yeah.
Okay, thank you. We have 10 minutes left. So somebody is also asking how to guide a sickle cell patient for self-management of their pain.
So I can take a shot at this. I think, it is important for sickle cell patients to feel comfortable managing pain at home. And this is something that, we try to teach in our comprehensive care programs. Probably the most important thing is to tell them these are the red flags that would say you need to seek out medical attention. And what I indicate is that if the pain becomes associated with fever, chest pain, difficulty breathing, or if there is evidence that the side effects of the pain medications are themselves becoming problematic, i.e. if the nausea is becoming too severe, or there's too much sedation going along with it, then they should seek out help. But otherwise, not to be fearful of taking pain medication at home. Sometimes we could say just give the clinic a call, just to let them know what you're doing if you're feeling nervous about this. But I think it's, I think it might be the analogy to an asthma attack. It's important for somebody with asthma to know when they can manage something at home and when they need to come in and seek help.
Wonderful. Thanks, Dr. Kirby. Do you have any additions?
No, that's well covered. Yeah.
Great. And Susan Ritchie is asking, what is the average length of stay in hospital for a sickle pain crisis?
Melanie, do you want to go first on that? Do you have?
So it a little bit depends on what we just talked about before, how comfortable the patient is with managing at home. So maybe I would say 5 to 7 days, but just one thing that we've recognized that's very important on discharge, when you're getting regular medication in hospital that's helping with pain management, when the patient is discharged, you can't stop the medication and expect the pain not to come back. So you have to know that as a caregiver, but also to teach that to the patients, so that when they go home with what I showed before, the WHO ladder of decreasing pain therapy as pain over time as pain improves. So then they can start withdrawing the opiates first, and then withdrawing Nsaids or Tylenol, depends on their comfort level also. And that will save bounce back to hospital, which is one of the reasons people bounce back to hospital if they just stop the pain medication. The other thing we see not uncommonly we used to see is patients would come to the emergency department, get an IV shot of opiate. Of course, the pain responds quickly because it's a good dose quickly. And then they get discharged on a tiny dose of oral morphine or hydromorphone. And then, of course, they will bounce back too. So whatever a patient is on in hospital IV, when they get switched over to oral, it has to be on an equivalent dose with a weaning schedule delivered to the patient.
Yeah, I totally agree with that. I would also add, and this is something which has to be approached, carefully, but you don't want to over medicalize your patients right from the get-go, because you're going to have to undo everything that you tied them to the hospital with before they can go home. So as an example, for sure, some people are going to need IV narcotics right from the get-go. But there should be a real effort to figure out what a adequate oral dose is as quickly as you can. Because if you have somebody in IV narcotics and then you say, okay, I think it's time for you to go home and I can switch you to oral right now on the day you're being discharged, the patients themselves can be quite fearful, understandably, about that. And you very well be wrong in what your dose is. It's it's a rough estimate to say you need about twice as much oral as you do IV, but you should really get that figured out while they're in hospital with you. And again, try to figure out a stable oral dose as early as you can, and don't give patients long-acting narcotic therapy while they're in hospital. It should be short-acting until you figure out what their 24-hour requirements are, and then you can transition them. So that's one thing. Similarly, Although patients may be dehydrated when they first come in and may need a little bit of IV fluids to kind of get them well perfused again, the old teaching about running the IV at 1.5 times maintenance is no longer recommended for sickle cell disease, particularly if the patients are able to drink. And I think it's much more effective to address whatever might make it difficult for them to drink, like if they're having a lot of nausea or stomach pain. But if they're able to drink, push oral fluids first before you rely on an IV. Again, it's something you're going to have to write an order to cancel, this kind of thing. Again, oxygen is important if the patients are hypoxic, or if they are like severely anemic, like a hemoglobin less than 50, in which case you want to maximize their plasma oxygen delivery. But if they're not severely anemic and their oxygen levels are greater than 95%, you don't need to put them on supplemental oxygen. Again, this kind of, it almost kind of disempowers the patient, to say, you have to come in, you get lined, mask, all that kind of thing. And it creates more anxiety about going home. So don't start things that you're going to have to cancel if you don't have to. The last thing I'll say as well is that there's a real tendency to transfuse every pain crisis that sickle cell patients present with. And it's because their hemoglobins are low, and there's this idea that if you transfuse them, that's going to shorten their pain episode. But in fact, it seems more likely to prolong it. The fall in hemoglobin that accompanies a pain crisis is in some ways adaptive. It's decreasing the viscosity of the blood. It's increasing perfusion to the microvasculature. And if you throw blood into the patient right from the get-go, you may just have them stay longer. I'll make one very, very last point here. Again,
we do have 4 more questions.
Okay. The last point I'll say here again is just, if you start off managing their pain in a very sort of reluctant, kind of like half dose kind of way, all you're doing is prolonging their hospital stay. So simple, straightforward care means a shorter hospital admission.
And just, Ziad, I know we're going to move on, just to mention stool softeners when you're giving patients opiates, because constipation is real and it causes a lot of pain in a patient in hospital for a long time on opiates.
Yeah, so I don't think it's going to cut us off at 1, but we'll just respect our attendees' time. I will mention that sometimes patients are admitted on a Wednesday and the team is discussing discharge planning on a Thursday. So that's a bit disconcerting on occasion, but we could just temper it with day-to-day reassessments. The next question, what medications you suggest to give the patients as outpatients to be used for pain at home herein?
Patients that we teach our patients, pediatrics and adults, to take all three types of medications, opiates. They may keep opiates at home, non-steroidals, whichever one works for them, ibuprofen or naproxen, and Tylenol. But they have to be taught how to use these medications together and when to use them, and it's quite safe to have them at home. But they need to be taught.
Yeah. Someone is also asking, I think most of us take painkillers every day. So should we present when our pain level is more than 8 or 10? Because the longer you wait, there's an increase in risk of complications, surely. At what point should they present if they're taking daily pain medications?
Well, I guess I would say that, the red flags that I mentioned, like if the pain is accompanied by fever or shortness of breath or chest pain or anything suggesting that there's, organ dysfunction going on, or if you cannot get the pain under control at home without inducing significant side effects, if you're feeling extremely nauseous or constipated or itchy or sedated or what have you. Beyond that, I don't know, Melanie, what you do, but I don't typically give patients a number to say when it's past this number in severity, come to the hospital.
Everybody's way of the numeric score is individual to what you might consider an 8 out of 10. Another patient might think is just a 6 or is a 10. So it's when you feel that you're not improving with what you're doing at home and you're doing all the things you've been taught to do at home, or if you have any of the red flags, then you come.
Yeah.
Someone asked, thank you for the wonderful presentation. What about the role of new medications in reducing the pain crises?
Yeah, I think it's there's a lot of really exciting research going on after a long period of very little happening in the field, where we only really had two therapies, hydroxyurea and transfusions, as disease-modifying therapies. There's a whole bunch of new stuff coming. Some things have been licensed for use, others are still in clinical trial. And then there's curative therapies. There's bone marrow transplant. We're getting better and better at it. It's becoming safer and safer. And then really excitingly, there's gene therapy. So there's a lot of stuff out there. I think it's just we just have to get the word out that although pain is sort of the cardinal feature of sickle cell disease, there's so much more to managing patients than providing pain medications. And I think that stuff really, you need to be in a specialized program to get access to that. And so there are probably not enough comprehensive care programs in Canada, but there's more growing, and we're always taking new patients.
Yeah, I mean, I'll also mention that, like you said, Jacob, it was very important to keep the patient warm. We have had patients leave the hospital because it just was not warm enough. They were not allowing them to bring in their electrical heating blanket from home because hospital engineers weren't okay with plugging it into the hospital outlet, etc. So there are some structural barriers that we have to advocate for patients sometimes, besides just the focus on opiates, as you said, and the new medications for sure. Mm-hmm. Next question: any special considerations for pregnancy and pain management?
Melanie, do you want to take that one?
I think when a woman with sickle cell disease, it becomes pregnant, then she should be in a comprehensive care clinic to start with proactively, and because they're different transfusions may be indicated during the pregnancy, but also just for improved and adequate care through the pregnancy in a high risk setting. In terms of opioids in pregnancy, the patients are treated in the same manner acutely. But then if it's sometimes our patients have frequent crises during the pregnancy, there might be a conversation about transfusion care during the pregnancy.
Yeah, I mean, I just add that we know that pain typically gets worse during pregnancy for sickle cell patients. First of all, because they have to stop their hydroxyurea, which might have been protecting them. But also just, as you get more and more pregnant, it becomes more difficult to, take a deep breath, so there's more dead space. There's the physical discomfort of, the loosening, SI joints and that kind of thing. So for sure, pregnant patients tend to be more uncomfortable with their sickle cell disease. It has not been shown that chronic transfusions will lead to better fetal outcomes in terms of pregnancy outcomes, at least not in the studies that have been done to date, but they definitely improve maternal outcomes. And we do know that if you give a lot of narcotics to a pregnant woman, there is a risk that the baby will be born with neonatal abstinence syndrome, which is basically a baby being born with opioid withdrawal, which requires its own specialized management. So my personal approach is, if I have a patient who had bad enough pain that they had to be on hydroxyurea, and then I have to hold the hydroxyurea while they're pregnant, I do tend to refer those patients for chronic transfusion during their pregnancies, just to avoid that kind of complication. But again, as Melanie says, this is a sickle cell patient who is pregnant is a high risk pregnancy on every level and should be hooked up with a high risk pregnancy program.
Yeah, some centers I know don't always stop the hydroxyurea during pregnancy after discussion with patients, but it's certainly something some physicians prefer, and that can make the pregnancy more symptomatic. So one question is, during pain crisis, non-opioids are recommended as an adjunct, but sometimes are not perceived as effective. Do you still recommend having them with the opioids?
It's interesting, actually. There have been some randomized controlled trials, not in sickle cell patients, but in patients who have like acute extremity pain, like a broken arm, for example, which is, pretty painful if you've got a broken arm, where they randomize them to either get narcotics or to get a combination of an NSAID and Tylenol. So they like Advil and Tylenol together, given at max dose. And they actually found that those two things together, Advil and Tylenol together, had as much narcotic or much analgesic effect as giving morphine. Now, I wouldn't say, therefore, that you should never give morphine, but I tell patients, go ahead and max out your Advil and your Tylenol. Take them both together at max dose, and you'd be surprised at how potent that can be. At the very least, it'll probably decrease the amount of narcotic you will also require. So I think we kind of tend to devalue those pain medications because they're non-prescription, but they can be very effective.
And I think when you hear that they don't work for me, it's usually because they're not on an adequate dose.
Mm-hmm. Mm-hmm.
They're taking one pill, which might be a 325 milligram Tylenol in a big person, for example.
Right.
The next question is regarding when to seek medical attention if you're already taking opiates and pain medications. Is it appropriate to indicate to come to the hospital when the number of doses has increased as opposed to the pain intensity?
Again, I don't typically go by numbers like that. I know it's sort of comforting in a way to sort of say like, okay, because you're agonizing, you're at home, like, God, do I go? Do I not go? It'd be nice to sort of have like a number to say, okay, like I'm past that point, I have to go. But I just find that that's hard for me to set as a global rule for every patient. It basically comes down to, are you in danger, which is sort of like, are you developing difficulty breathing, for example? Or are you just not coping? Like, can you just not cope at home? And those are kind of hard things to put numbers to. But I think if there's it's just a very complicated thing. And like I said in one of my slides, whether you seek out medical attention often has a lot to do with, are you totally alone? Like, are you completely isolated? Or do you have friends around you? Do you have people caring for you, sort of, bringing you meals, that kind of thing? That stuff makes a huge difference if you've got a support network, and it's hard to put a number on that. So I couldn't give you a formula, unfortunately, for that.
I think if I could just add, if a patient starts feeling fearful of taking their medication at home, then they should come. Yeah. Because the fear will add more pain and anxiety, and fear and anxiety will increase your pain, and they wouldn't relax. And you need to have a more of a try to relax and have a more relaxed mind to help.
Yeah, absolutely. And the final question is, are NSAIDs continued during pregnancy?
Yeah, that's complicated. I think it depends on when during the pregnancy. If you start really early, there's a risk of polyhydramnios, and if you're too late, you can get problems with cardiac issues. So to be totally honest, I don't actually know what the current recommendations are of this, because it does seem to change frequently. But for the most part, I say avoid NSAIDs unless you've specifically been given the go-ahead by your obstetrician.
Final question. Can you determine if someone is actually having a crisis by blood work rather than symptoms?
You may have tuned in a little later, but this is definitely not. If the patient is telling you they're having a pain in their arm or leg or back or whatever, they're having pain, and we have to believe them. There's nothing in the blood work that really, you may see a drop in hemoglobin from baseline, but that isn't always the case. You may see an increase in the LDH, but they have chronically high LDHs. But there's nothing really in the CRP is often a little bit up. It might get a little higher in a crisis if there's an associated fever and infection, but really you have to believe the patient. There's nothing on the blood work that really will tell you yes or no. There is, if you start seeing a fall in platelets, fall in hemoglobin, then that, and respiratory distress, then that is more, that is that's telling you that things are not going well. But there's just for a VOC episode without uncomplicated, nothing, no changes in the blood work.
Yeah, and depending on the genotype, the hemoglobin can be very close to normal. So SC have close to normal hemoglobin. So often that's not mentioned by the patient in terms of their sickle cell type. So that can be hard to utilize. Okay, well, thank you so much to our speakers and our attendees for the very engaging conversation we had. Sanjeev, feel free to remind everyone about our upcoming events.
Yeah, so I think also from our side, real big thanks to our speakers for their great presentation on pain management, our healthcare workers attending today, Dr. Soul for helping to moderate this session and the Q&A. Just a quick reminder, as mentioned earlier, two big things we want you to take away as well. The first is on June 19th, which is World Sickle Cell Day. There is a special advocacy best practices session also being hosted by several of our policymakers who are responsible for championing Bill 255 into law. And the registration link is below, as well as on the SCAGO website. The second is the social media campaign for the first inaugural World Sickle Cell Disease Day or Awareness Day. And the ask is really to wear red or black t-shirt to show support and of course tag on social media. So really appreciate everybody's participation. And lastly, when we close this session, as mentioned, there's a really quick survey, and we read all the comments, we take all the feedback into consideration as we design new webinars, new sessions, really tailored for our community in Ontario. So really appreciate your feedback so we can always continue to improve as well. So with that, a big thanks from our side, and thanks again to all the speakers, and looking forward to next time.
Okay, take care.
Everybody.
Bye. Thank you all for
Bye.
joining.
Bye-bye.